I'm happy to have myself and Dr. Bowe as moderators for this evening. For those of you who have not had the privilege of meeting, I'm Dr. Dennis Spencer. I am one of the board members for Building the Next Generation of Academic Physicians. I'm the founding treasurer of this organization. But I'm also a clinical fellow at Boston Children's Hospital and Harvard Medical Schools. I am a physician scientist with an MD and a PhD, focusing largely on translational work, looking at host microbe interactions with the gut microbiome, one of the areas that have become quite interested among many individuals in GI. But I have a number of interests within diversity as well. So I'm excited to hear and learn from our speakers this afternoon.
Good evening, everyone, and I'm really delighted to be here. My name is Aaron Baugh. I'm a clinical fellow in pulmonary and critical care medicine at the University of California, San Francisco. My long-term career interests are in medical education, and actually with a specific focus in health equity outcomes and how we can improve that from an educational standpoint. So I'm excited to be talking about that with you all a bit later on this evening. This is my first event with the Building the Next Generation of Academic Physicians, and I'm really honored to be a part of it.
Okay, thank you so much, Dr. Baugh. So I did wish to, for those of you who are on this call, I would imagine you were aware of this because you're on our mailing list for BENGAP. But for those of you who are not familiar, our mission is to help diverse medical students and residents become aware of academic medicine as a career option and to provide resources to further explore and potentially embark on an academic medicine career. For the purpose of tonight's webinar, if everyone can try to mute themselves, sometimes the ambient noises wherever you are may interfere with everyone hearing, but that'll help us greatly this evening. Our president for BENGAP that many of you have met is Dr. J.P. Sanchez, who was also the founder of the organization. Dr. Sanchez, are you available on this call? And if there are any remarks you would like to give?
You're doing great, Dr. Spencer.
Okay. Well, we always are happy to have Dr. Sanchez around to help these discussions. But just for looking towards the horizons, we have a number of activities this year for you. So please be on the lookout for future webinars. We'll try to have webinars of interest, in particular relevant to different months that have focuses on individuals from diverse backgrounds. Tonight's webinar is in part in celebration of Black History Month. But we do plan to have webinars that'll specifically address women, that'll address Spanish, Hispanic heritage, and other groups. So please be on the lookout for those. Also, we have ongoing regional conferences that will discuss areas for academic medicine, career development, and leadership. You can see that we've already just had one at University of California, Davis School of Medicine. And today at the tomorrow at Indiana University School of Medicine. But you can look on this list as well as on bengap.org for our future regional conferences to get more information like we'll be discussing tonight. There's also our annual LGBT Health Workforce Conference, this year again in New York City. That'll happen in May, and registration details should hopefully be available to you who are on our listserv, but again, go to bengap.org for more details. And finally, later this summer, we'll have our second Clinical Transitions Conference for those of us who are going from one place to another in our academic journey. So for those residents and fellows going for their first academic appointment, for those junior faculty who are looking for advancement within their respective tracks. So we do hope that everyone will continue to look at that as well. And I'm sorry, I did forget to mention the medical students. Medical students will be going into residency, a very important group for the Clinical Transitions Conference as well. So please be on the lookout for CUNY School of Medicine in August of 2019. Now, we have these workshops, and some of you have heard this before, that reflect what we know is a need. We know that many of us have interests in becoming faculty, and that there are a growing number of schools, allopathic medical schools, as well as osteopathic, that are coming about that are looking for individuals to serve as faculty members. But we do know that with this increased number of opportunities to become faculty at these new institutions, that the underrepresentation still persists, and that URMs still make up about 30% of the US population, but only 16% of medical students, 7% of faculty. And you can see our other demographic numbers here listed. But certainly we know there is this continued discordance, and we are hoping to be able to address that through the mission of BINGAP and through such vehicles as this webinar and the aforementioned conferences. We do know that there were a lower proportion of underrepresented minority medical students than those who were non-URMs that reported an interest in academic medicine careers, as published by Jeff et al. In 2008. And that is something that we wish to address as well. We wish for there to be more individuals who are interested, but in part, we know that this is because of a lack of knowledge of what it means to be an academician and to become faculty. One of the areas that tonight's discussion in particular will address is the importance of publication. It is important for medical students to know that publications are important, but this is definitely one important mediator to your success in becoming an academician. So we do hope that that is something that you'll gain from here, greater appreciation of how to be successful with publishing. So just again, to have an idea for what the opportunities for publications that exist. We do discuss within BINGAP the importance of our collaborators that provide many opportunities for publishing. One great collaborator of ours has been MedEd Portal, which is an important online open access vehicle for publishing academic content such as new curricula and other areas within education, within medical education. And a lot of these workshops that we've done, we have been able to publish in establishing a curriculum that has been informed by you, informed by focus groups with similar groups as yourself. And this has led to now multiple MedEd Portal publications. And here is a list of some of those medications. But again, this is an opportunity for publishing and an opportunity for you to, again, enter into academia, trying to focus on areas that are of interest to you. And the final plug for one of our strong collaborators has been Academic Medicine. You will hear tonight from two authors of papers that were featured in Academic Medicine. But Academic Medicine is the official peer-reviewed journal of the Association of American Medical Colleges, and is a high-impact journal that speaks to many of the challenges that face the academic medicine community. And it is, again, an excellent place to publish your work. They do have 12 issues per year. As I mentioned, the impact factor is quite significant, especially within the medical education space. And that there are a number of focus areas that may align with your particular interests. So we're bringing this to your attention of the multiple opportunities within academic medicine, the journal specifically, within MedEd Portal, but then just in general, making sure that you're publishing your important content and your particular incentive. Tonight's discussion We're going to highlight publications by African-American focused work and their inclusion in medicine. We're also going to talk about the importance of publishing this type of content because we know that for years this type of content may not have been in these scholarly works. So we'll discuss that, as well as the best practices for medical students, residents, and fellows who wish to publish their own content of particular relevance to their community. Our first presenter will be Dr. Samantha Kaplan. Dr. Kaplan, she is an assistant dean for diversity and multicultural affairs at the Boston University School of Medicine. She's also an assistant professor of OBGYN. And she recently published in 2018 an article in Academic Medicine that was entitled Race, Ethnicity, and Success in Academic Medicine, Findings from a Longitudinal Multi-Institutional Study. So with that, I will let Dr. Kaplan further introduce herself, as well as introduce her scholarly work.
Good evening. So I wanted to start by telling you just a little bit about how I got into academic medicine. I think I was drawn initially to the idea of teaching, and I gave very little thought to the currency of success or advancement. So I had absolutely no idea that I needed to put together a portfolio of publications or a curriculum or mentoring. And 7 years into my time at this institution, I was waiting for somebody to ask me if I wanted to be promoted, not realizing that I was supposed to ask to be promoted, and I was supposed to argue on my own behalf that I had adequately met all of the requirements to advance in academia. I'm very lucky. I'm at an institution that does not have tenure, and there's no track, so I was fine with that, which was great. But I immediately recognized after my first promotion that I needed to be publishing. So what you're going to hear is one of 8 articles that came out of a group of researchers. I was very lucky, and I will talk more about this, to find this group of women who were doing research into underrepresented, marginalized, or disadvantaged faculty, specifically women and underrepresented minorities. So the background behind this piece of work is that, as mentioned in one of the earlier slides, the population of the groups that represent the demographics that are underrepresented in medicine exist in our general population at a reasonable amount. There's 32% of the population, and the medical student diversity, while still less than that at 16, 17%, and it was 17% at the time this paper was written, is still lower. It's better than, however, than the faculty, which is at 8%. And so the question is, what is going on? Why are we doing a slightly better, though not fantastic job, getting medical students into medical school, but we still don't have people who are in faculty positions? And this is really important because I found that I didn't see anybody who was like me when I was in medical school. I honestly, I won't say where, but where I went to medical school, you can look at my bio, I don't think I saw a single person who was not touching patients. I certainly was not taught by people in any of the preclinical years, nor did I receive lectures in the clinical years, with the exception of one individual who was the Dean of Diversity. And that is a travesty, because seeing people who are like you allows you to envision what it is you want to do. Perhaps I would have had that conversation earlier about how I could be successful. You need people to mentor you and educate you and be a role model. Without the contributions of people who are diverse, obviously, there's not going to be sufficient curricular breadth, which will do patients a disservice, but will also do learners a disservice. No one other than the people who are very vested are going to really advance research around disparities and equity. And by vested, I mean people who can identify with some of the issues that might arise with these disparities. And we also need to change the face of what excellence looks like and what academicians look like. And in the absence of that, we're always going to anticipate that our teachers and educators will be white men. So I looked a little bit and I realized that there were a couple case studies and there were departmental studies, but there wasn't a study looking at what the boundaries and the barriers were across institutions. So this study had previously been done in 1995 with a Robert Wood Johnson Fellowship, Robert Wood Johnson Foundation grant, and it looked at 24 institutions from all of the regions that the Association of American Medical Colleges identify. So great geographic representation. These were institutions that had at least 200 women and a significant number of underrepresented minorities back in 1995. And the original sample had been oversampled for women and underrepresented minorities by taking any underrepresented minorities that had graduated from medical school after 1970, because there were not a lot, and we really wanted to include people. That survey gave rise to a significant number of publications, and our task was to go back and look at the 1,300 people who said they were willing to be interviewed again. Advance the slide, please. Do you mind? There, excellent. So we went back to the same 24 schools and the people that were there, and we asked them a bunch of qualitative questions, but more importantly, we reached out to the people who had answered the surveys before. And we got about 50%, 48% response rate on those people who had agreed to answer, who were still alive, because we did have some deaths. And we were able to come up with a validated method to search databases to get information on the other people who had agreed to be notified with respect to their academic productivity, their rank, and their leadership positions at their institutions. We were not able to gather information about our other two outcome measures, which were satisfaction and compensation. But between the gathering through what we called web sleuthing and the surveys, we had a lot of information. And that information was interesting. We looked at it with respect to the Caucasian population, the non-underrepresented minority population, because we all know there are many people who are minorities in the population who are not minorities in medical school, and then the underrepresented population. And on the next slide, you can see some results. Now, mind you, before I talk about these results, I will say we asked these same questions specifically about women as well, and actually found many similarities in addition to some disparities in compensation for women. But what was notable is that underrepresented in medicine faculty on resurveying had a significantly lower number of publications as a measure of productivity. They also were significantly less likely to be promoted to the rank of professor, and their retention in academia was very, 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 very significantly less, as you can see by that p-value. We then went and corrected for all of this information, correcting by gender, correcting by time in academia when the first survey took place, number of publications when the first survey took place. And after all of that, we found that the relative ratio for publication for people who are underrepresented in medical academia compared to Caucasian professors was 0.64. So for every one article that a Caucasian person would publish, a person of color would publish, 0.64 articles. The odds ratio for advancing to the rank of professor with correction was about 50%, where 50% is likely to make it to the rank of professor, starting with the same number of publications and the same amount of time in academia. And the likelihood that you would stay in academia had an odds ratio of about 50% as well. So this would explain why, when we look around, there are significantly fewer people who look like us, teaching us. We did some work looking at prior articles that identified barriers, and we came up with very similar information. Our qualitative study pointed to lack of mentorship, lack of structured programming, lack of critical mass, meaning you get someplace and then you leave because you don't see anybody who's like you, which was, I think, one of the motivators for me to be engaged in this study. I wanted to try and create a body of work that would keep me at this institution and in my role, so that when the students looked around, they would see me. Now, I will say, there's 8 articles that came out of this body of literature, and there's research rather, and there's one more that is out there. Without advocacy and publicizing your own work, even at my institution, many people have no idea that I've done this work. So that is a piece of being successful in terms of publishing that I am still learning about, that I don't, again, think anyone had ever told me. But I did learn some lessons in terms of getting published that I would like to share. And Dr. Spencer, you'll tell me when I'm out of time, right? Okay. One lesson is that you need experienced people to help you when you first start, and they need to be experienced on every level. So that would mean, for me at least, I didn't know how to submit or revise an article. I had a pretty decent idea about how to write one, but as soon as we started getting enough data to submit something, I had never answered all of those forms. I had never answered all of those disclosures. I had never put together a chart explaining my revisions or answered questions about my tables or responded to editors' concerns. I didn't know about the format. I didn't know about the expectation. And honestly, even after making it all the way through medical school, I was scared to ask my research team. I felt that my position on the team would somehow be undermined. So I had found this amazingly supportive team, which is what many of us need, but I didn't really know how to go about publishing or responding. So I had to learn how to ask for help. I then had to learn how to ask about, I would say, the next step. So with this data, where else could we go? Can we share it with something else? Do we need to write some comparative papers now? Does our success and our number of citations allow us to be valid commentators or write letters to the editor about other articles that come out? How do I stay abreast of that information so I can begin to build a body of knowledge and literature in a particular niche, which is what it takes to be promoted? No publication is too small. I should be writing letters to the editors, but I have to find the articles. And then the last thing I would say that I learned is when you are thinking about writing and joining a team, or even writing a piece by yourself, I think it's very important to identify what you individually can contribute, and then also identify what you can get from that contribution, how you will be able to leverage it, the networks that you will be able to create, because that is also a significant part of your advancement.
Reggie Bohl is a full professor at the University of Toledo College of Medicine. He's also the assistant dean for admissions at the same institution. And he first authored, actually single authored this paper in academic medicine recently at the tail end of 2018. So if you would like to proceed, Aaron.
Sure. So I Am an African American is a perspective piece. Rather than being built around new empirically derived data or statistical analysis, the backbone is really only a reasoned argument. Like other forms of academic publishing, it required a lot of mental rigor and a willingness to engage with contemporary scholarship on the issue. The specific focus or issue that was being addressed was what was the importance of distinguishing between African Americans and other Blacks of non-US origin. And I think to really understand this question, we have to take a step back and sort of contextualize in the broader context of medical school admissions in the United States. If we go to the next slide. Okay, so despite our aspirations to the contrary, public opinion polling among physicians really mirrors broader societal trends in a number of ways, whether you're looking at the decline in empathy over the last few decades, or looking at something about biases that are held about attitudes of wealth and poverty, or about minority groups, for instance. Now, at the same time, a recent poll sponsored by the Robert Wood Johnson Foundation reported that up to 1 in 5 African Americans avoid necessary health care because of previous episodes of discrimination and concerns about facing those again in the future. And further, if you look at underrepresented minorities in medicine, they're more likely than the average physician to practice in medically underserved areas. So putting all this together, it really does matter who we choose to bring into this profession is going to define the shape of its future. And so as we go forward to the next slide, please. In that light, it is, not just peculiar, but really perverse that although in this 30-year period here, the number of available seats in American medical schools has increased by over a quarter, and that the number of underrepresented minorities that are attaining undergraduate degrees in the life sciences that would prepare them for medical school is increasing. And that over the same period, the number of minorities as a fraction of the US population is increasing. Matriculation to medical school has remained basically flat. And it's when we try to grapple with this problem that we can come back to the central inquiry of this perspective piece, which I think is what happens when we try to flatten the topography of something as rich and as complex as our heritage, yours or mine or all of ours, right? And I think there's a couple important ways that we can ask this question and look at it in the next slide here. Consider, for instance, that Africans have the highest educational attainment of any immigrant group that comes to the United States. And when you put that besides the fact that Black physicians, so whether African American or from Africa or another part of the African diaspora, tend to have disproportionately higher debt burdens upon graduation than their white counterparts. You wonder whether lumping first generation trainees with Native African Americans obscures the extent to which debt is a barrier or a deterrent to people really having interest in the field of medicine. Or take, for instance, the benefits of diversity in the workplace or in the learning environment, which really depend on people being willing to share of themselves. In fact, evidence suggests, and I think that some of you might be able to bear this out in your own personal experiences as you reflect, that when someone is, feels too isolated or alone in an environment, what they might instead tend to do instead of manifesting those diverse characteristics is that they might submerge those differences so that they can be like everyone else. And this is a concept called critical mass. So if two people that are labeled the same because, they're both called Black on the admissions box, don't feel similar enough to have that robust camaraderie and to inspire that confidence in one another to show those diverse characteristics, are we losing out on some of those benefits of diversity, I'd ask? And finally, let me talk to you a little bit about the importance of patient-provider concordance. And those benefits we see in long-term disease management and medication compliance and joint decision-making. I don't think that's about just cosmetics. I think it would be silly to say that it's just about the skin tone or the sound of a language that's happening in a room. It's something much deeper about those 1,000 nonverbal cues, the shared cultural references, the understanding and the viewpoint that lets a doctor and a patient make a connection to one another. Now, in spite of my best efforts, I know that that's not something that I can replicate for a Somali American patient, for instance, as well as could a provider that has a shared palette of personal and cultural experiences that they can draw from to make that connection. And I would ask that in an increasingly diverse society like the United States, with an increasing number of non-African American Blacks, don't those patients deserve the chance to have the same special connection and the same benefits of concordance that my African American patients do? And likewise, don't African American patients have the right to really experience the unique power of that therapeutic alliance of someone that understands more deeply what their experience has been and can, communicate with them in a way that may be more efficacious. So I think overall, whether we look at this from a standpoint of being, students in training, or whether we look at it as patients seeking care, or administrators trying to develop a better medical system, we are all disserviced by a model that willfully ignores nuance. No one is a monolith. And this perspective really argues for going beyond checkbox diversity and evaluating holistically each candidate to see what unique viewpoints and contributions that they could bring to the classroom in considering their education. So that was kind of the purpose or the summary of this article, What is an African American? Dr. Spencer, if you'd like me to move on to kind of tips for publishing, or?
Absolutely. If you can, in the next couple of minutes, just give your thoughts on what made you successful, or things that you consider are important tidbits for our audience.
Sure. So I think Dr. Kaplan hit on a lot of great points, which I would echo. The two things that I would say have really helped me are, number one, be well-versed in the literature, read deeply. You're going to, be able to see that way where the gaps are and what are the things where you can add your voice and make a contribution. You have to first know what's already been said and what the discussions are to insert yourself. That's the first thing I would say. The second thing I would advocate and stress is really the importance of mentorship and mentor-trainee kind of relationships. Having someone who's gone before you and can give you advice to point out and say that, this is something that you need to be doing, or you're not focusing on the right thing. And, not only understanding it from the receiving end of, having someone to look out for you, but, what does it mean to be a good mentee? There are ways that you can be of service to your mentor and make that a productive bilateral relationship that's going to be more fruitful for the both of you. And, think about seeking out those things, and that will really enhance your career in the long run. I think those are my two strongest recommendations to everyone here this evening.
Well, thank you for that, Dr. Bowe. And again, I do encourage everyone to think of questions for our speakers. Again, we're getting a good variety of the types of work that are being published or that can be published. And I would love for us to get to a healthy discussion about the importance of these perspectives being out in the literature. So our final speaker tonight will be Dr. Boatwright. Dr. Boatwright, he is an assistant professor of emergency medicine at Yale School of Medicine. And he is the author of this recently published work in JAMA entitled Association Between the Liaison Committee on Medical Education's Diversity Standards and Challenges in Percentage of Medical Student Sex, Race, and Ethnicity. So without further ado, Dr. Boatwright.
All right, Dr. Spencer, thank you so much for having me, and I'm really honored to be a part of this panel. Just a little bit of background about myself. Again, I am in emergency medicine. My research interests focus on bias and discrimination in medical education, and also interventions to promote diversity in the healthcare workforce. And in particular, I try to have an emphasis on systems level interventions that can actually promote diversity. And to that aim, early last year, I was actually reading about the Liaison Committee on Medical Education's Diversity Accreditation Standards. And the LCME, or the Liaison Accreditation of Medical Colleges, they're responsible for the accreditation of all medical schools, and there's certain policies and procedures that medical schools must have in order to maintain in good standing and not be placed on probation, and essentially to have a well-functioning operational medical school. And part of those are diversity accreditation standards that were actually introduced in 2009. In essence, those standards just say that a medical school must have policies and procedures in place to promote a diverse medical student body, diverse group of faculty, and also administrative staff. And when I realized that those standards had been implemented in 2009, I realized that almost 10 years had passed and it would be an interesting time to evaluate those standards and to see if they've actually increased or had an effect on medical student diversity. In particular, we wanted to focus on the matriculants, the percentage of matriculants, again, based on sex, race, and ethnicity. Dr. Spencer, do you mind advancing the slide? So from the AAMC, we were actually able to obtain data from all medical schools from 2002 to 2007, looking at the percentage of women matriculants, Black, Hispanic, Asian, and white matriculants as well. And essentially what we wanted to do is to see how those percentages had changed over time, in particular, looking at 2009 when the diversity accreditation standards were implemented. So as you can see from this graph, when we look at the percentage of women from 2002 to 2009, the percentage of women was actually decreasing each year. 2009, the standards were introduced, and then you can actually see about 3 years later, there's actually a reversal in that trend, and the proportion of women actually began increasing by almost 1% a year. Dr. Spencer, do you mind advancing to the next slide? The trend for Black matriculants is very similar. From 2002 to 2009, the percentage of Black matriculants is actually, again, decreasing every year. The standards were introduced in 2009. You see a plateauing of that decrease. And again, in about 2 to 3 years later, the trend reverses and the percentage of Black matriculants actually begins to increase. And Dr. Spencer, do you mind advancing to the next one? Interestingly, the trend for Hispanic matriculants was increasing before the standards from 2002 to 2009. But as you can see, after the implementation period of the LCD standards, the trend for the rate of increase for Hispanic matriculants almost doubles. And do you mind advancing to the next one, Dr. Spencer? And for Asian matriculants, you can see before the standards, the percentage of Asian matriculants was increasing each year, but that rate of increase essentially plateaus after the diversity accreditation standards were implemented. And Dr. Spencer, for the last slide. And as you can see, the trend for white matriculants was essentially stable from 2002 to 2009, but moving on from 2012 to 2017, you can actually see there's what we call an interval decrease, rather, of about 4% for the percentage of white matriculants that enter medical school after the standards were introduced. So essentially, what we took from this is it seems as though the diversity accreditation standards have been effective. We have seen positive trends in the rate of increase for the percentage of matriculants for white, Black, and Hispanic matriculants. I'm sorry, for women, Black, and Hispanic matriculants. Of note, though, that rate of increase, especially for Black and Hispanic matriculants, has been small. So I think moving forward, I think we're very interested in ways that we can alter the LCME standards to actually operationalize them, to actually enhance these rates of increase. And also, we're also interested in understanding what medical schools have done that have been particularly successful after the LCME standards were introduced. And those policies and procedures that those schools have implemented could be best practices for medical schools looking to increase the diversity at their institutions as well. In terms of, and that's essentially the summary for the research. In terms of just advice that I would give in terms of being successful for publications, again, I think the advice that the current panelists have already given has been stellar. I think the only thing I would add at this point is, I think one of the key features is just to always be curious. And part of that curiosity is even challenging or thoughts that are just assumed to be true. I know when we started this research, whenever I spoke with program directors of residency programs or people on admissions committees and medical students, it's challenging to increase diversity because the pool of talented minority applicants is small. And I heard this time and time again, and it seemed as though no one really kind of challenged that thought. And I agree on some level, yes, the pool of talented applicants is small, but I think one of the things that this study shows is that in the right operational environment, when medical schools were forced to actually have policies and procedures to promote diversity, diversity increased and increased relatively quickly. So I think, again, challenging assumptions and just always asking that next question as to why is this the case and what can we actually do about it or ways to be successful in the writing career.
Excellent. So thank you again, Dr. Boatwright, for that summary. And again, it's really important that we are demonstrating the impact of these diversity standards. I do have questions from the audience, but one of which for Dr. Boatwright, since you just finished, that we have from one of our participants, is whether or not you can speculate whether the recent ACGME diversity requirements, if that might affect recruitment of URMs for residency, and if you might see a similar type of trend as we're seeing with the LCME. Dean, you have any thoughts on that?
You know, I'm extremely excited about the ACGME diversity accreditation standards. So I think I'll say a couple of things. So one, if you look at the data around the implementation of the LCME diversity standards, many medical schools actually struggled with these standards initially. I think there's data showing that about a quarter of medical schools were actually given a citation 3 years after the standards were implemented because they failed to meet these standards. So I think I'd imagine most residency programs have not even thought about ways to increase diversity. And I think many programs will also experience citations and secondary to a lack of any effective or implemented policies. That being said, I think over time, I think what we're going to see is I think we are going to see increasing diversity across programs. And I think what we're also going to see is that programs are going to start engaging in more pipeline activities as well.
Excellent. And this is more for the rest of the panel, but I know that Dr. Kaplan said something very striking, that many of her colleagues were not aware that she had published this work and been a part of this group that's had 8 publications now, or at least another 8 other publications kind of speaking to diversity. That, you know, is something that I wonder if others have experienced, one, and then 2, if this is something that Dr. Kaplan has any specific thoughts on how to kind of be a better cheerleader for your own work and the trying to tell others the importance of this work that you're doing.
I do have some thoughts. I think as a group, underrepresented individuals suffer more significantly from this thing that we call the imposter syndrome. And I think that as a whole, academia has a very ironic name, the ivory tower, right? And so, you know, I think ivory has all sorts of meanings, but in this particular case, it wasn't intentionally chosen to reflect racial difference. It was actually value. Ivory is very, very rare. But I think in academia, we are even less likely to feel the validity that allows us to toot our own horns, as it were. However, we also lack the colleagues and the network that others have to have their horns tooted for them. We do not have, let's say, if you're a woman, you don't have the Old Boys Network. If you are a woman of color, you don't have really any network. And so I think you have to take the initiative yourself to put your work out there and not see it as a risk or be concerned that it is not valid. I guarantee you, because I tried once before this, and I read academic medicine, the work would not be in there if it were not considered valid. There's no charity in publication. So first of all, you have to have the confidence to do that. But it all takes confidence. It's confidence to ask people to allow you to be part of their research, to identify an idea and bring it to a faculty member and say, I have this great idea, but I need your support or your IRB or your guidance and assistance in moving this forth. You have to have some sense of confidence and validity to do that. And we're often not positioned in such a way to do that. Again, stemming from the fact that we do not see it done by people who are like us often. And so sometimes it is a very big first step to take, or a very big bullet to bite, as it were. But I will say that I often find people talking to me about the advancement of women or the advancement of underrepresented minorities in medicine without knowing that I've written this and without any legitimacy themselves, which I think it is up to me at that moment to say, interesting that you should bring that up. Let me tell you a little bit about my research.
Excellent. Does anyone else have any other comments about this idea of being a self-promoter and making it clear the importance of getting out this type of information relating to our community?
You know, I think Dr. Kaplan brings up a great point as well about relying on the community as well, and also maybe other organizations such as BINGAP, SNMA, and so forth. And I think as leaders in these organizations too, I think BINGAP's doing a great job, and I thank you for helping us promote our papers even tonight. But even having a Twitter feed among these organizations that can highlight work by minority researchers would be a great way to help spread the word as well.
Excellent. And Dr. Kaplan also mentioned that, you know, in doing her own self-promoting, because there was a lot she did not know when she first entered academia, she mentioned the idea of letters to the editor. Now, this is certainly a vehicle, a type of a publication that one can have that is an opportunity that many can take advantage of, and with irrespective of their place in their training. Academic medicine specifically had a call for letters to editors from trainees that just happened this last fall, looking specifically for medical students, residents, and fellows to publish. But among our panelists, have you taken advantage of writing letters to editors? And do you have any thoughts that might be of use to our audience about approaching a letter to an editor?
So I wrote letters to the editor before. So I want to say last year I actually read an article in Academic Emergency Medicine that essentially did a very small literature review of studies that looked at implicit bias in emergency medicine and the impact it had on patient outcomes. And they actually concluded that implicit bias had no impact on care provided by emergency physicians. And I thought the interesting thing about that was one of twofold. One, academic emergency medicine has almost never published anything related to bias and discrimination. And they published this paper. All the authors on this paper were white. And when I actually read the paper, their data didn't, to me, even suggest that their conclusion was accurate. So I'm part of an organization in emergency medicine called the Academy of Diversity and Inclusion. And as a committee, we actually sat down really just over the course of 3 days and wrote a very quick letter to the editor explaining the flaws that we thought were present in this piece and why this piece was actually potentially harmful. And we actually gave them other bits of evidence that's been published showing how implicit bias does affect patient care. And, you know, just over the course of a couple of days, I think we were able to, one, get a publication, but also kind of refute this false narrative that was out there as well.
And that is very important, I think, for our listeners to hear. Letters to editors are, number one, among different types of publications that one can submit. You can have original research articles, you can have perspective pieces like you heard this evening, but then letter to editors are sometimes directly rebutting or just addressing a recently published article of work. It can be a call. As mentioned with academic medicine, there'll sometimes be an all call for letters to editors on a particular topic. But it's an opportunity to have Dr. Boatwright has mentioned, a brief communication that is typically limited to the number of words that can be included, as well as the number of authors. Generally, no more than 3 is one of the kind of common rules, that you can get your perspective out there and address an article like Dr. Boatwright's group did that does not seem to really speak the truth of what their data would suggest. And it's just important for individuals from underrepresented groups to address these types of issues at times, because you wonder if they did not respond to that letter, would it have been just assumed as true and that important perspective would not have been heard? That's one of the points we want to get across for this evening's discussion. These articles are written by individuals from diverse backgrounds who have this unique perspective and view of the importance of diversity standards, or the way that you would interpret this data on diversity, than our counterparts would. And it's an important perspective and voice to hear. We need to be included in the role of the people at the academic center as new faculty, but we also need to make sure that our voice is being heard in the literature. It is something that has been missing for too long, and something that it is up to us to address. A 60-second final thoughts about where they would like to leave tonight, the last impression for our participants.
Mhm.
We can start with Dr. Kaplan.
So I think one of the most important things from my perspective is something that you just alluded to, Dr. Spencer, which is, what is the role of the academician of color who is underrepresented in academia? Are you limited to only writing about things that have to do with people of color? And I would say, of course not. That's insane. Your thoughts about everything are as legitimate as anyone else's. I think the gift that you have to bring is a perspective, an experience in moving through the practice of medicine, whether it is through education or whether it is through patient encounters or whether it is through hospital administration or management. It doesn't really matter what it is. You have a unique perspective because you are of a group that is very underrepresented in almost every venue in which you will practice as a professional. And so you will have questions and insights and an awareness that is not shared amongst your peers. And it is in that area where you can add even more. Your primary research may have nothing to do with race and ethnicity, but that's an area where you can add more. And honestly, sometimes you get tired of being the squeaky wheel, but I will say that if you're not asking the questions, nobody is going to. And if you are not writing the articles, no one is going to. And even if they were, just as Dr. Boatwright pointed out, they might not get it right. And do you want to hear it from them when you have known for years that it's been going on anyway?
Excellent. Dr. Ball, do you have any thoughts?
Yes, I would echo that thought, and I would say that as we see in the patterns of practice distribution in medically underserved communities, if it is not you who is speaking, there will be no one else. If you do not stand, there will be no one to stand for, for our communities. These, whatever passion you have, you should pursue, absolutely. But if your passion is in this research around underserved communities, in whatever aspect that you tackle it, that is real, it is important. You're making fundamental contributions to medicine. There are both things that are of insight in setting minority populations that are generalizable to all communities that you can serve through your work. And equally, there are things that have been generalized that may not apply to one particular minority community. And you will save lives and you will help people by identifying those things. Pour your heart out into what you care about. Don't be afraid that, like, I'm going to pigeonhole myself or something,
If you aren't the one, there'll be no one else. That's an excellent word. All right, Dr. Boatwright, any final thoughts from you? Let's see.
I am muted. I'm sorry about that. So, I just encourage everyone to write and let your voice be heard. And like Dr. Kaplan said, every paper is important, and every paper can affect countless lives over decades.
Excellent. So once again, I would like to thank our panelists for taking the time to speak to our audience this evening. And thank you again, audience members, for listening. Again, we're interested to hear from you. So please be on the lookout for more information on bengap.org, but also feel free, once you have any new questions for today's discussion, to contact me or Dr. Sanchez directly. Again, thank you for your time. And at this time, we will end tonight's webinar. You guys have a great evening.